Praise be to Allah, the cherisher and sustainer of the worlds. I'm Dr. Ramsha Mushtaq Khan, and today I have the opportunity to present on the topic measles under the kind supervision of Professor Dr. Saira Afzal. Quote of the day: everything begins with a thought, and thoughts are turned into plans, and plans into reality. Content outline: number 1, introduction to measles. Number 2, dynamics of disease transmission. Number 3, epidemiological determinants. Number 4, clinical features and complications. Number 5, prevention and control measures. Number 6, milestones towards global measles elimination and recent advances and multiple choice questions. At the end of this presentation, the participants will be able to understand the pathophysiology of measles, including phases of infection and its complications, describe the dynamics of disease transmission and the epidemiological determinants, discuss strategies for preventing and controlling measles, including vaccination, herd immunity, quarantine measures, and disease surveillance, and recognize the global recent advances in the context of measles. Measles is a highly contagious viral infection transmitted through airborne droplets, causing a range of symptoms characterized by fever and catarrhal symptoms of the upper respiratory tract, including cough and coryza and conjunctivitis, followed by a typical rash. Measles symptoms, the 3 C's: cough, conjunctivitis, pink eye, and coryza, runny nose. Dynamics of disease transmission. The medical model of an infectious disease includes a source or reservoir, modes of transmission, and a susceptible host. In case of measles, the source is the measles virus belonging from the paramyxovirus. The reservoir is infected humans and environmental surfaces contaminated with virus. Modes of transmission include droplet infection and direct contact with a person infected with measles. And the susceptibility of host depends upon age, vaccination status, immune status, and underlying health conditions. As we have discussed, the chain of infection includes the infectious agent, a reservoir, modes of transmission, the portal of entry and portal of exit, and a susceptible host. The epidemiological determinants include the pathogen, the susceptible host, and the favorable environment. The agent factors include, for the measles virus, include the paramyxovirus from the RNA virus family. Agent is the paramyxovirus, the source of infection. Only source of infection is a case of measles. Period of communicability, approximately 4 days before and 4 days after the appearance of rash. And secondary attack rate is 90% to 100% in susceptible individuals. Measles virus is a highly infectious during the prodromal period and at the time of eruption. Host factors. Age affects virtually everyone in infancy or childhood between 6 months and 3 years of age in developing countries and more than 5 years in developed countries. Immunity. Infants are protected by maternal antibodies up to 6 months of age, and immunity may persist beyond 9 months. Measles tends to be very severe in malnourished children, carrying a mortality up to 400 times higher. Environmental factors. Cases occur throughout the year. Peak incidence is in winter and early spring. Incubation period is 10 days from exposure to onset of fever and 14 days to the appearance of rash. Clinical features. The measles is divided into 3 phases. Number 1 is the prodromal phase, number 2 is the eruptive phase, and number 3 is the post-measles phase. Prodromal phase. Initial phase of the illness and typically lasts 2 to 4 days. During this stage, individuals may experience the following symptoms. Fever, a high fever, typically over 101 degree Fahrenheit, is often the first symptom of measles. Malaise, individuals may feel generally unwell, tired, and have a lack of energy. A dry cough may develop and individuals may experience a runny or congested nose. Conjunctivitis, red and watery eyes, often with sensitivity to light, may develop. Koplik spots, small white or grayish spots may appear on the inside of the cheeks. These symptoms may not immediately suggest measles as they are similar to those of other respiratory illnesses. However, the presence of Koplik spots is a highly suggestive sign of measles. Eruptive phase. Often the first indication of the disease in children is the eruptive phase. Typical dusky red macular or maculopapular rash, which begins behind the ears and spreads rapidly in a few hours over the face and neck and extends down the body, taking 2 to 3 days. Progresses to the lower extremities. Rash may remain discrete, but often it becomes confluent and blotchy. Recovery phase. During this phase, the rash will gradually disappear and the other symptoms will begin to improve. However, individuals may still experience some lingering effects such as fatigue and weakness. In rare cases, individuals may experience complications of measles during the post-measles phase. These can include bacterial infections of the respiratory tract, ear infections, or more serious complications such as pneumonia or encephalitis. The telltale signs of some classical illnesses, the comparison, measles include the rash that starts on the face, red eyes, and a bad cough. Mumps have the swelling above the jaw plus aches, fevers, and other flu-like symptoms. Rubella has a rash on face lasting for 2 to 3 days. Chickenpox has itchy red palms that appear in clusters plus flu-like symptoms and produces intense coughing with a distinctive whooping sound. Complication of measles. Number one is otitis media, number two is pneumonia, and number three is diarrhea. And the major complications include febrile convulsions, encephalitis, and subacute sclerosing panencephalitis. The overlap of complications between measles and rubella or congenital rubella syndrome, the triad includes brain damage, deafness, and blindness. Prevention. Number one is the live attenuated vaccine, a single dose of 0.5 ml subcutaneous vaccine at 9 and 15 months. Age can be lowered to 6 months if there is a measles outbreak in the community. For infants immunized between 6 months and 9 months of age, a second dose should be administered as soon as possible after the child reaches the age of 9 months, provided that at least 4 weeks have elapsed since the last dose. Immunoglobulin. The dose recommended by WHO is 0.25 ml per kg of body weight, and it is to be given within 3 to 4 days of exposure. Person passively immunized should be given live measles vaccine 8 to 12 weeks later. The need for immunoglobulin is now much reduced because of the availability of an effective live attenuated vaccine. This is the latest EPI schedule with MR, measles and rubella 1 at 9 months and MR2 at 15 months. It is given as the subcutaneous injection on the left upper arm. The diagnosis of measles is based on a combination of clinical signs and symptoms and laboratory testing. The laboratory tests include throat swab culture and blood tests. Number two is the IgM antibody testing, and number three is the PCR, which can detect the genetic material of the virus in a sample of blood. An IgM antibody test can detect the presence of antibodies produced by the body in response to the measles virus. This test can be helpful in diagnosing measles in someone who has not been vaccinated or who has not had the disease before. Measles and HIV, vaccination should be routinely administered to potentially susceptible asymptomatic HIV-positive children and adults. Vaccination may be considered for those with symptomatic HIV infection that if they are not severely immunosuppressed. 2 additional doses of measles vaccine should be administered to these children. Outbreak control measures, isolation for 7 days after onset of rash. Immunization of contacts within 2 days of exposure. If the vaccine is contraindicated, immunoglobulin should be given within 3 to 4 days of exposure. Prompt immunization at the beginning of an epidemic is an essential to limit the spread up to 70%. Challenges for measles elimination. Number one is the weak immunization systems. Number two is the high infectious nature of measles. Populations that are inaccessible due to conflict, increasing refusal of immunization by some populations, changing epidemiology of measles, need to provide catch-up measles vaccination, gaps in human and financial resources. Milestones toward global measles eradication. Raise routine coverage with the first dose of MCV to 90% nationally and 80% in every district. Reduce and maintain an annual measles incidence to less than 5 cases per million and reduce measles mortality by more than 95%. Now it's time for the recent updates. The Global Strategic Plan for Measles Elimination. So this comes from the Vaccine Alliance Gavi, which announces global partners to launch new plan to control and eliminate measles and rubella. The increasing measles outbreak prove need to bolster investment and political commitment to reach global goals. This is the joint news release from American Red Cross, CDC, UN Foundation, UNICEF, and WHO. This strategic plan, 2012 to 2020, explains how countries working together with the MR initiative and its partners will achieve a world without measles, rubella, and congenital rubella syndrome. The plan builds on the experience and successes of a decade of accelerated measles control efforts that resulted in a 74% reduction in measles deaths globally between year 2000 and 2010. It integrates the newest 2011 World Health Organization policy on rubella vaccination, which recommends combining measles and rubella control strategies and planning efforts, given the shared surveillance and widespread use of combined measles rubella vaccine formulations, that is MR and MMR. The strategy focuses on the implementation of 5 core components. Number one is achieve and maintain high levels of population immunity by high vaccination coverage with 2 doses of measles and rubella containing vaccines. Number two, monitor disease using effective surveillance and evaluate programmatic efforts to ensure progress. Number three, develop and maintain outbreak preparedness, response rapidly to outbreaks and manage cases. Number four, communicate and engage to build public confidence and demand for immunization. And number five, perform the research and development needed to support cost-effective operations and improve vaccination and diagnostic tools. These are the core components of Global Measles and Rubella Strategic Plan, as we have discussed. Now, the Global Strategic Plan for Measles and Rubella Elimination in WHO Southeast Asia region 2020 to 2024. The guiding principles include country ownership and sustainability, RI and health systems strengthening, equity, and leveraging on partnerships. The key milestones by the end of year 2022 has been that all countries will have developed a post-elimination sustainability plan along with an outbreak preparedness and response plan. 5 countries will have maintained their rubella and measles elimination status. An additional 2 countries will have been verified for measles and rubella elimination. Additional selected subnational areas of large countries will have interrupted transmission of indigenous measles and rubella. By the end of year 2023, measles and rubella transmission will have been interrupted in the entire WHO Southeast Asian region. 7 countries will have been verified for measles and rubella elimination, and the remaining 4 countries will have interrupted indigenous measles and rubella transmission. And by the end of year 2024, all 11 countries will have maintained the interruption of transmission of measles and rubella and will be verified for measles and rubella elimination by 2026. This is the weekly epidemiological record by World Health Organization, measles and vitamin A. Vitamin A deficiency contributes to delayed recovery and to high rate of post-measles complications. In addition, measles infections may precipitate acute vitamin A deficiency and xerophthalmia. As a result, measles accounts for a large proportion of preventable childhood blindness, particularly in Africa. The beneficial impact of 2 doses of vitamin A during treatment of measles is well established. WHO's current policy advocates administering vitamin A to all acute cases. A high dose of vitamin A is given immediately on diagnosis and repeated on the next day. The recommended age-specific daily doses are 50,000 international unit for infants aged less than 6 months, 100,000 international unit for infants aged 6 to 11 months, and 200,000 international unit for children aged more than 12 months. If the child has clinical signs of vitamin A deficiency, such as white spots, a third dose should be given 4 to 6 weeks later. Even in countries where measles is not usually severe, vitamin A should be given to all cases of severe measles. Now, the multiple choice questions. Number 1. In a developing country XYZ with low vaccination coverage for measles and poor environmental conditions, the most vulnerable age group for measles infection is A up to 3 months, B up to 6 months, C up to 3 years, D up to 6 years, and E up to 5 years.
C?
Yes, the answer is C, up to 3 years. A local hospital has seen a significant increase in pediatric patients with measles symptoms, including high fever, cough, runny nose, and a red blotchy rash. In order to prevent the potential epidemic of measles in the community, the age for immunization should be lowered to A 3 months, B 6 months, C 9 months, D 12 months, and E 24 months.
B?
Yes, the answer is B 6 months. A severely malnourished child from a remote village presents with symptoms of measles infection, dry scaly skin, and night blindness. In order to prevent delayed recovery and post-measles complications, the dose of vitamin A to be administered should be A1, B2, C3, D4, E5.
A?
No, the answer is C. 3 doses should be given. Number 4, the sibling of a 3-month-old infant develops measles. The infant may not be infected with measles despite the exposure due to passive immunization by the presence of maternal antibodies up to the age of A 3 months, B 6 months, C 9 months, D 12 months, and E 24 months.
B?
Yes, the answer is B 6 months. A previously unvaccinated child presents with high-grade fever, cough, and small white spots inside his mouth. The doctor recommends isolating the child as he is in the phase of A. Incubation, B. Prodrome, C. Eruption, D. Recovery, and E. Post-measles.
B?
Yes, the answer is B. Prodrome, because this is complex spots are the pathognomic of measles. A 5-year-old girl who has been in contact with other children with similar complaints is recently diagnosed with measles. In order to describe the symptoms, the healthcare provider uses the term 3 C's of measles, which means A. Cough, cold, conjunctivitis, B. Cough, coryza, congestion, C. Cough, cold, congestion, D. Cough, coryza, conjunctivitis, and E. Cough, chills, and conjunctivitis.
D?
Yes, the answer is D. Cough, coryza, and conjunctivitis. A 7-year-old boy presented with complaints of high fever, cough, and sore throat and is diagnosed with measles. The parents notice a characteristic rash with raised, itchy bumps on his body. The measles rash usually first appears on the A. legs, B. abdomen, C. trunk, D. arms, and E. face.
C?
No, the answer is E. face. The rash time starts behind the ears. The health department identifies a large outbreak of measles in a particular community. In order to prevent further spread, a mass immunization campaign is launched, which, if promptly implemented, can prevent measles cases up to A 30%, B 40%, C 50%, D 60%, and E 70%.
D?
No, the answer is E 70%. 9. A child of a known case of an HIV infected drug abuser presents to the hospital and the diagnosis of measles is made. The doctor should prescribe measles vaccine to the child in addition to the dosing schedule of EPI in quantity of A, 2 additional doses, B, 3 additional doses, C, 4 additional doses, D, 5 additional doses, and E, 6 additional doses.
A.
Yes, the answer is A, 2 additional doses. Number 10, a 7-year-old child presents with a rash and fever that began 4 days ago. The child had recently attended a school function where several other children were also present. The period of communicability for measles is A, 1 day before and 1 day after the rash appears, B, 2 days before and 2 days after the rash appears, C, 3 days before and 3 days after the rash appears, D, 4 days before and 4 days after the rash appears, and E, 5 days before and 5 days after the rash appears.
C.
The answer is D, 4 days before and 4 days after the rash appears. This is the key of the MCQs. Please like and subscribe our YouTube channel. And thank you very much.
Thank you very much, Dr. Amsha. Very nice presentation and very well presented. And thank you very much. Thank you all the students. Inshallah, we would follow the roster and see you all very soon. Allah Hafiz.
Allah Hafiz, ma'am.
Allah Hafiz, ma'am.